Director of Continuing Medical Education. We would like at this point in time to thank Dr. Ablock for her years of outstanding service in this role. Today, we're going to be discussing a very, very important topic in the form of breast cancer screening. According to the World Health Organization, breast cancer is the most prevalent cancer globally. In the United States, for 2023, it is estimated that 297,000 women and 2,800 men will be diagnosed with invasive breast cancer. Having a closer look at our statistics, breast cancer is the leading cause of cancer among Bahamian women. Screening is an important tool in the fight against breast cancer. Today, we will be updated on breast cancer screening methods to equip us with the current evidence-based guidelines to better help the patients we serve. We are pleased to have with us today Dr. Dawn Major presenting on breast cancer screening. Dr. Major is no stranger to us, but for those of you who may not be familiar with him, I will provide a quick refresher. Dr. Major is a graduate of the University of the West Indies, St. Augustine's. He did his surgical residency at UWI Bahamas, where he became the first Bahamian to complete the UWI Bahamas Surgical Residency Program. He completed his surgical oncology and hepatobiliary fellowship at the Tom Baker Cancer Center in Calgary, Alberta. He is currently a consultant surgical oncologist and hepatobiliary surgeon at the Princess Margaret Hospital. Please welcome Dr. Major.
Hi, good morning. Can you hear me?
Yes, we can hear you.
Awesome. Thank you, Dr. Wallace-Bain, for those kind words, and thank you for having me here this morning to present on breast cancer screening. So I'm just going to pull up my screen now and just let me know if you guys can see it.
Yes, we can.
Awesome. All right. So like Dr. Wallace said, I am a surgical oncologist and hepatobiliary surgeon at both Princess Margaret and Doctors Hospital. And this morning, we're just going to be doing a brief overview on breast cancer screening, some of the pitfalls and some of the reasons why it's so important. When we look at breast cancer, for more than half a century, cancer screening has been an important component of the struggle to reduce the burden of morbidity and mortality from cancer. As per GlobalCon data in 2020, the number of new cancer cases diagnosed in 2020 alone was 19.3 million. And of these patients, almost 10 million actually died. GlobalCon predicts that number of cancer cases will increase to about 28.4 million by 2040, showing us that this cancer issue is not going anywhere and it's getting worse. So according to GlobalCon data, breast cancer is the most commonly occurring cancer in women and the most common cancer overall. There are more than 2.26 million new cases of breast cancer in women in 2025 alone, which makes up about 25% of all new cancer cases. According to a study done in 2018, female breast cancer incidence rates have been slowly increasing by about 0.5% per year since the mid-2000s. Theories behind why this is happening is because of possible decline in fertility rates of young women, as well as an increase in excess body weight. And for the first time, female breast cancer has become the most commonly diagnosed cancer, surpassing lung cancer. The mortality of female breast cancer has peaked, however, in 1989 and has since decreased by 42%. Thoughts as into why this is happening is because of earlier diagnosis due to screening and increased awareness, mammography screening, and finally, improvements in our treatment options. Declines in breast cancer mortality have slowed in recent years, however, from 2 to 3% annually during the 90s and 2000s to 1% annually from 2013 to 2019, reflecting the slight but steady increase in incidence and stagnant mammography uptake in recent years. When we look at the SEER database, where we look at death rate per 100,000 women based on race and ethnicity, we see that our Black women have the highest death rates of 27.6 per 100,000, showing that it's a very prevalent and serious issue in our women of color. When we look at percentage of deaths by age, we see that majority of women die within their 70s from breast cancer. Now, this is all US data, mind you. Our data looks a bit different. So screening. It is accepted that screening mammography prevents deaths from breast cancer. Debates continue, however, about the absolute size of mortality benefit conferred and concomitant risk associated with the screening. Some of the questions arising are, why do we screen? When do we screen? Who do we screen? And how do we actually screen these women for breast cancer? First of all, we want to go into what is screening. Now, a screening test is a test that can be carried out on people who do not have any symptoms, so totally asymptomatic, but these individuals perceived to have an increased risk for a particular disease. And in this case, we're talking about breast cancer. It predicts the likelihood of someone having or developing a particular disease. It does not tell you whether or not that patient has the condition. Instead, screening sorts people into two groups. People who have an increased chance of having the condition, so they have a positive screening result, and people who do not have an increased chance. So basically, they have a negative screening result. The two major objectives of a good screening program are, one, detection of disease at a stage when treatment can be more effective than it would be after the patients develop signs or symptoms, and identification of risk factors that would increase the likelihood of developing the disease, and use this knowledge to prevent or lessen the disease by modifying these risk factors. So we need to determine what is the ideal screening tool. The ideal screening tool is actually capable of detecting a high proportion of disease in its preclinical state, so totally no symptoms, asymptomatic. It is safe to administer. It is reasonable in cost. It leads to demonstrated improved health outcomes. It's widely available, as must the interventions that follow a positive result. So you need to be able to treat whatever it is that you find. Effective screening programs, therefore, should both increase the incidence of cancer detection at an early stage, as well as decrease the incidence of cancer presenting at a late stage. Now, however, to be effective in reducing mortality in the population, the proportion of the population screened must remain high. And one of the factors actually limiting the success of any screening program is the low compliance. When we look at compliance from European countries, we see that about 82% of women from Denmark between 50 to 69 years of age actually got their screening. And if you compare that to Romania, 0.2% of these women. So it shows that in certain places, they have a very high incidence or a very high compatibility with screening, and they actually follow their screening programs. So why are some of the reasons that compliance may be low? So the primary factor limiting compliance with screening mammography is, one, low health literacy. Health literacy represents the degree to which individuals are able to obtain, process, and understand the basics of medical information in order to make necessary health decisions. So again, the population is not aware, is not adequately informed with respect to the role of screening, the importance of screening, and why should they continually do it. Other things such as socioeconomic factors such as ethnicity, education, income, or employment are also significant factors in whether or not patients actually undergo screening. Given that patient compliance with mammography is less than 50%, efforts to increase health literacy are paramount. You need to get this number much higher in order to see the real benefits of screening. Though mammography remains the gold standard for initial screening, exams to detect breast cancer, limitations do exist. Mammography has an overall sensitivity of about 85%. However, when a patient has dense breasts, that sensitivity decreases to about 68%. Hence why we tend to preserve the mammography for individuals at the age of 40 and older, because their breasts tend to be less dense. Our younger women, we probably use a different modality to determine whether or not whatever symptom they may be experiencing is something to worry about. In addition, critics point to the low specificity of an abnormal screening mammogram. So many biopsies performed for an abnormal mammogram show no evidence of cancer and lead to unnecessary anxiety and high costs. And when women have to get those callbacks imaging, it can lead to even more anxiety. You were already worried about your mammogram, you got the mammogram screening, and then 2 weeks later they say, oh, we need to do another test. So now they start to worry, is there something there? Do I have cancer? Do I need to now figure out what I'm going to do moving forward? So proponents for mammography screening agree that an abnormal screening mammogram does not frequently lead to a cancer diagnosis. However, it points out that less than 10% of patients require additional further testing or further views for clarification, and less than 2% of women who are screened actually undergo biopsies, and about 30 to 40% of these actually show breast cancer. Randomized controlled trials have consistently shown a reduction in mortality in patients screening with mammography. These authors point to the data from the Canadian National Breast Screening Study in their analysis. A recent population-based mammography service screening study, which included 2.7 million women from Canada, that demonstrated a mortality benefit of 40% in women who actually participated. Duffy et al. Re-examined the 4 highest profile reviews: the UK Independent Review, the Nordic Cochrane Review, the US Preventative Task Force, and the Euroscreen Review of mammography service in Europe. When the authors estimated breast cancer mortality reduction using corrected data that maintained the same screening and follow-up periods, all indicated a substantial reduction in breast cancer mortality with screening alone. In Sweden, at the time of the introduction of a nationwide mammography screening, the policymakers chose the age of 40 as the lower limit in approximately half of the country and 50 in the remaining half. At their 16-year observation, mortality from breast cancers diagnosed at the age of 40 to 49 years was significantly lower in those countries that offered screening starting at the age of 40. And that is what we recommend here in the Bahamas, that we start our screening program from the age of 40 years in our average risk Bahamian women. So what are some of the biases associated with mammography screening or screening in general? So early detection through screening implies advancement in the time of diagnosis of the cancer from what have otherwise occurred in the absence of screening. Now, the concept of lead time refers to the length of period of time of this advancement. So because diagnosis is before any symptoms, it is possible that in the absence of screening, clinical diagnosis would have never occurred, either because of the inherent indolence of the cancer or competing causes of death. So a little diagram showing lead time bias. So as you can see here, let's say this patient was to live for 100 years. When we screen them at the age of 40 and about 50, we find the cancer and they live for another 50 years. We could say that they were cancer-free for about 50 years. But if we don't screen them and they develop a cancer at 75 and they still live to 100, can we truly say that the screening has helped, right? This is what we talk about when we talk about lead time. There's this time of almost about 50 years with respect to them actually being diagnosed with screening and them actually developing the disease. So did it lengthen their time of life? Hard to say. So this phenomenon of screening detecting a cancer that never would have otherwise become clinically apparent is known as overdiagnosis. Overdiagnosis and lead time are theoretical concepts in that they can generally not be observed in a given individual, but can be estimated statistically in populations. Overdiagnosis occurs when the time to other causes of death is less than the patient's lead time. Simply put, this means that the patient would have died from another cause before her breast cancer was advanced enough to cause her death. Lead time bias and overdiagnosis can lead to scenarios and observational studies where screening seems to be beneficial, even though the modality may actually have no effectiveness on reducing mortality from breast cancer. Bly et al. Suggested that there's a substantial overdiagnosis, accounting for nearly a third of all newly diagnosed breast cancers over the age of 40 in the United States, and argued that screening has only a small effect on the rate of death from breast cancer. Another bias in evaluating the effect of screening is selection bias. This issue arises when one examines the cancer-specific mortality rate among a group undergoing screening to that in a group not undergoing any screening, or to population-wide statistics. Because those who choose to be screened may be different with respect to the incidence and survival from the cancer of interest. These underlying factors, and not the screening itself, may be contributing to any observed differences in mortality rates between the screen and non-screen or population-wide group. When we look at some of the harms of screening, in general, there are few medical harms of the actual cancer screening tests themselves. Modalities that rely on X-ray radiation, low-dose CT mammography, do convey some added risks for cancer development. However, that excess risk is generally acknowledged to be quite small. The primary medical harms of cancer screening come from downstream events, the diagnostic workups of false positive screens, so the biopsies, taking the patients to surgery, etc. The diagnosis and treatment of cancers that may have never clinically become apparent without screening, so overdiagnosis and overtreated cases. It's truly hard to say how many of these cases are actually overdiagnosed and overtreated, because many a time, if you do identify a cancer, we cannot say whether or not it's indolent or it's going to be rapid growing. Now, although these rates per screen are low, for many screening programs, patients may undergo 20 to 30 screens over their lifetime. So the lifetime risk of experiencing a complication is substantially greater than the one-time risk. Also, at mass screening of healthy populations, the absolute number of people with complications as a result of screening-induced diagnostic workup is considerable. There's a difference between screening and diagnostic evaluation. With respect to screening mammography, individuals go ahead and they generally get two views, the craniocordial view and the medial lateral oblique view. But the diagnostic evaluation, they get a few more views, and the reason being is because they actually have a pathology present. So they have a lump that's present in the breast. And now it's not necessarily screening, it's more diagnostic to evaluate this problem. So what makes up the components of breast screening? Basically, it's dependent on the age and other factors such as medical and family history. It includes breast awareness, patient familiarity with their breasts. So basically just understanding what your breast feels like, what it looks like in the mirror. When you take a shower, every so often you kind of do a little examination per se of your breasts, just to make sure that there are no abnormalities that you may discover. You also want regular clinical encounters. So this is where you actually have your breast cancer risk assessment to determine whether or not you are a high risk or an average risk person for developing breast cancer. And at this time, a clinical breast examination should be performed by the physician. Breast imaging generally is in the form of a screening mammography. Sometimes, depending on the age and the risk of the patient, they may end up getting a breast MRI. At the clinical encounter, complete medical history followed by breast cancer risk assessment and clinical breast exam is what happens. In a review of controlled trials and case control studies that included clinical breast examination as a part of the screening modality, sensitivity of clinical breast exam was found to be about 54% and specificity about 94%. Overdiagnosis and overtreatment is not a significant issue with clinical breast exam, as the majority of palpable cancers found on breast exam tend to be invasive carcinomas. NCCN panel recommends breast awareness, specifically that all women should be familiar with their breasts and properly report any changes to their healthcare provider. So it's not that we're asking these women when they go home to do a self-breast examination where they have to generally go through all the quadrants and in a systematic manner like a physician would do. But again, like I said previously, we just want to make sure that they are aware what their normal breast feels and looks like. So if any abnormality may present itself, then these women would be able to report to their healthcare provider and trying to determine exactly what's happening. So when we look at the risk assessment now, how do we actually put these women into high risk and average risk? So if the physical examination is negative in asymptomatic women, the next step is to determine risk stratification. Women tend to be stratified, like I said, into average risk and increased risk. The increased risk women, so which women are these? These are the women who have a prior history of breast cancer. They have some risk assessment models. The most common one that we tend to use is the Gale model. And this is used in women over the age of 35, and it gives you a 5-year risk assessment of invasive breast cancer. And if your number is greater than 1.7%, these women are considered increased risk. Women who have a lifetime risk of developing cancer greater than 20%, based on them having a previous history of lobular carcinoma in situ or atypical hyperplasia, whether it's lobular or ductal, doesn't really matter. Women who have a lifetime risk of 20% or greater, as defined by models based on their family history, as well as their genetics. And then women between the ages of 20 and 30 with prior thoracic radiation, or what is known as mantle radiation. And women who have a pedigree suggestive of or known genetic predisposition. So the BRCA1, BRCA2 gene, these women are increased risk, and they develop or they go beyond in a different screening program compared to our average risk women. So this is the dreaded mammography that most women, they have complaints about, but sadly it is the most sensitive test that we have right now for picking up early cancers, because the MRI cannot necessarily see things such as microcalcifications. So digital mammography has actually replaced film mammography, because I remember back in residency in clinics, we'd be looking at the films trying to determine exactly what that is that we see. But now it's all on the computer, and it generates an electronic image of the breast and allows for computer storage and processing of the image, thereby increasing the ability you want to be able to detect subtle abnormalities. Digital mammography has significantly more accurate in younger women with dense breasts, and there's a non-significant trend towards improved accuracy of the film mammography in older women aged 65 years and older. So it seems to still be a role for film mammography, but I don't know if we still have it available. More recently, combined use of digital mammography in conjunction with digital breast tomosynthesis improved breast cancer detection and reduces the actual false positive callback rates. Tomosynthesis allows for acquisition of a 3-dimensional data using a moving X-ray and digital detector. I think quite a few centers here in the Bahamas now have tomosynthesis, and I think that is what they generally use for screening for our women. These data are reconstructed using computer algorithms to generate thin sections on the imaging, and it can be combined with the 2D mammo, results in however, it doubles the radiation exposure compared to mammography alone. When we talk about the tomosynthesis, it's actually about 7 X-rays for one mammography, 7 chest X-rays for one mammography, which is relatively low dose. However, this increase in radiation dose falls below dose limits of radiation set by the FDA for standard mammography. And the radiation dose can be minimized by newer tomosynthesis techniques that create a synthetic 2D image, which may obviate the need for conventional digital imaging. Now, when we look at the ultrasound, it's more or less used as an adjunct to the screening mammography. So it's unlike the mammography, ultrasounds lack any evidence from randomized controlled trials of screening efficacy, although ultrasound is widely used in the diagnostic setting. In women, however, with dense breasts, the mammography sensitivity is found to be about 50%, and sensitivity of mammography plus ultrasound actually increases about 77.5%. So generally, you would send a lady from a mammogram, and they would report it that it's kind of incomplete. They would give it a BioRad 0 score, and they would request an ultrasound to determine whether or not there's truly something that is there. The routine use of ultrasound as a universal supplementing screening test in women with average risk is not recommended by the NCCN panel at this time. And ultrasonography is commonly used for diagnostic follow-up of an abnormality seen on screening mammography and palpable clinical concerns. When we look at MRI as another screening tool, the sensitivity of the MRI at detecting breast cancer is higher than the sensitivity of mammography, although the specificity for the former procedure is often lower, resulting in higher rate of false positive findings. The microcalcifications that we see on mammography are not detectable with MRI. And then you can imagine MRI is way more expensive. But we do use the MRI for screening in certain individuals. And these tend to be the individuals who are considered increased risk or high risk. The American Cancer Society has published guidelines recommending the use of breast MRI as an adjunct to screening mammography in certain populations, like we said, the high risk individuals. Nevertheless, a high false positive rate with screening MRI has identified in several studies. For example, in one study of high-risk women, many of whom were young and had very dense breast tissue, screening MRI led to 3 times as many benign biopsies as mammography. So generally in these high-risk women or increased women, they tend to get a screening modality every 6 months. So they would get a mammogram in 6 months, then they would get an MRI in 6 months, mammogram 6 months, MRI in 6 months. So every 6 months, they're doing a screening image to determine whether or not they have any early signs of breast cancer. For NCCN screening recommendation panel continues to support its long-standing recommendation of annual screening mammography beginning at the age of 40, as it results in the greatest mortality reduction, most lives saved, and most life years gained. When we look at various screening centers or screening guidelines, the NCCN starts at the age of 40 and they continue annually, and they consider severe comorbidities and limiting life expectancy based for their stopping age. The American Cancer Society, again, they start at 40 and they go to 44. They go basically to 10 years left in their life expectancy. And they tend to do it annually from 40 to 54, and then every other year when they get to over 54. However, the U.S. Preventative Task Force, they start at the age of 50, and they do it every other year. And generally, like we say, when we stop the mammograms is if they're 75 and, they have coexisting comorbidities, you don't suspect that, they'll last another 10 years, then, you can decide whether or not it's okay to stop your mammogram at that time. So generally, women at the age of 30, they should seek medical attention with their family physician to determine their risk of developing breast cancer. So this is where we do their risk assessment, whether it's the Gale model, we take a history, physical, and we determine, their family history, whether or not they have any relatives with breast cancer or any other form of cancers to see if these are increased women, increased risk. If they're deemed average risk, then they start their screening at the age of 40 up until 75, depending on comorbidities and life expectancy. But if they're considered high risk now, the screening may begin earlier, depending on the family member that may have had breast cancer and their age of developing it, as well as depending on, in addition, they will need to have the mammogram as well as the MRI for high-risk women. This, what I thought was an important picture where we see that 1 in 6 women actually develop breast cancer, and it usually occurs in around the age of 40 to 49. So 1 in 6 breast cancers occur in the ages of 40 to 49. And this 70% here shows that there was a Harvard study that showed that individuals with breast cancer that developed, 70% of these women never had any screening, right? So 70% of these women who actually had breast cancer and they also died from breast cancer never had any screening or never had screening more than 3 years that were more than 3 years. So again, showing the mortality benefit associated with screening, trying to catch this disease early, and trying to minimize all of the other treatment adjuncts that need to happen for these individuals. When we look at World Cancer Research Fund international breast cancer death rates, We see that, the Bahamas is right up there with respect to deaths from breast cancer, with Barbados being number 1 in the world and the Bahamas being number 4 with respect to cancer-related deaths from breast cancer. So a little graph showing us the various models in which we can use to determine risk assessment. And again, like I said, we tend to use the Gale model, where we look at the age of the person, age of menarche, age at first live birth, if they've had any breast biopsies that showed atypical hyperplasia, and if they have any family history of first-degree relatives with breast cancer. So in conclusion, screening for breast cancer should begin at the age of 40 in our average risk women. So we've gotten a question with respect to, whether we should think about screening earlier. Again, right now, as it stands, all the societies talk about the age of 40 as our starting age for screening. We do develop some women younger than the age of 40 with breast cancer. So we may need to look at our population data and determine whether or not this may be an age that we may want to decrease. There has been great mortality benefits identified in women who are screened for breast cancer. Mammography remains the imaging modality of choice, and ultrasound and mammogram can be used as useful adjuncts. Thank you. And I'll entertain any questions at present, if you guys have any.
Hi, good morning. Can you hear me?
Hey, yes.
I have a question, if that's okay.
Yep.
And a comment. So, a fantastic talk. This is Cooper. I think you did a very good job of sort of summarizing the status of breast cancer globally and in the Bahamas. But one thing I wanted to sort of emphasize was the breast cancer risk assessment. So we know that in the Bahamas, you got somewhere between 300 and 500 people that are diagnosed every year with breast cancer. And probably, I think I saw something like 45 or 42% of these people who are diagnosed at stage 3 or stage 4. And it's very likely that these people will die from breast cancer. I'm pretty sure that the majority of the women who will die from breast cancer have seen a primary care physician at some point in their life before death, either in childbirth or for a pap smear or whatever the case may be. And I think that the primary care physicians, and I'm glad that we're having this forum, have an opportunity to address that risk cancer assessment, right? Because a lot of these women, they may go and get screened, they may not, they may have a mammogram, they're not consistent with it. But I think that the majority of these women are not aware of their breast cancer risk based on family history. If you have a relative, a first-degree relative that has had breast cancer, particularly at a young age, or if you've had more than one first-degree relative or even a second-degree relative with breast cancer, the likelihood of you developing breast cancer during your lifetime is very high. And that's where these risk assessment tools come in. And so what I wanted to sort of re-emphasize with the primary care physicians is that when these women come into your door, for whatever reasons, they come in for a cold or a cold or a skin rash or for a pap smear, that's your opportunity to discuss risk. Because women are more likely to get a mammogram if you tell them, look, based on your risk assessment, your risk of developing breast cancer during your lifetime is 40%. That's almost a surety that you're going to get breast cancer. And we know from what you presented, Dawn, that breast cancer screening is different for high-risk women as opposed to low-risk women. So we shouldn't be telling these women, even if it's not available to all of them in the public sector, we shouldn't be telling them that you just need to get a mammogram. We should tell them what the standard is and allow them to make the decision based on their finances, how they're going to get screened, but at least give them the information. One thing that we're doing at NHI is making this breast cancer risk assessment tool available. So you gave some really high level information about what's in these tools, But these things are online, they're readily available, almost like MedCalc, where you can sort of plug in some information and tell a woman if she's high risk or if she's average risk. So I just wanted to kind of sensitize the family medicine physicians, the primary care physicians about breast cancer risk assessment. And you can go online, you can Google the Gale model. There's another one, the IBIS score, just so that you can see. And you can ask these women while they're in your office, take a few minutes, the first time you see them, do you have anybody with breast cancer in your family? Go through a few of the questions and assess their risk of breast cancer. So I guess what I wanted to say was more of a comment than a question, but I do want to ask, when you're seeing these women who are diagnosed with breast cancer in your office, how many of them have, and when you're doing your history, have a positive family history of breast cancer in your experience?
A great comment, number one, and great question. It is interesting to find that, number one, not a lot of them know their family history. So it's kind of a challenge to really go down that family history lineage to determine whether or not, they have any family history of breast cancer. They may know mom, probably grandmother. The rest of it kind of gets a bit shady, right? But when I do see women with breast cancer, surprisingly, I would say probably the majority of them don't have any family history, to be honest, right? Which is kind of goes against what I would expect to see. But when you actually look at the data, they said about 70% of women that do develop breast cancer tends to be sporadic, so no real genetic or family predisposition. So it is important that, you do find out the family history, because if they do have, multiple relatives with breast cancer, or they have multiple relatives that were young when they diagnosed with breast cancer, that's another important thing. Because I had a lady the other day, she has been diagnosed with breast cancer, and basically her grandmother had it, but her grandmother had it at the age of 80. So again, she kind of had it in that time period when you would more or less expect it. Now, if she had it when she was in her 40s, then you would say, okay, maybe something's going on here, so that the age in which their first relative has been diagnosed is also quite important.
And one last question: what's the status of BRCA testing in patients with breast cancer in the Bahamas? Is this something that you guys routinely do when the patients are presenting late stage at an early age? Is it something that's free to the public, even without insurance? Just give me some more information about BRCA testing for our breast cancer patients.
Okay, well, BRCA testing basically is just a mouth swab. However, it's not presently free for the public patients. There is a cost associated with it. I think it's about $500. And the other thing is that we generally do it on our women who are younger that develop breast cancer. So they're under the age of 40 and they have breast cancer, then we kind of automatically recommend that they should get a BRCA testing, as well as if they have like a really strong family history, right? Then we'd say, okay, yeah, we should probably look into your lineage and do a BRCA test. But most commonly reserve it for our younger women that are developing breast cancer.
Can I comment on Cooper's original comment?
Yep.
I think we have to acknowledge that our breast cancer statistics and presentations are markedly different from the rest of the world. And the comment I want to make is, where are we with our national breast cancer screening program? Because I think that's probably what's going to make the difference. If we have a standard national screening program that everybody's aware of, I think that would save a lot of lives, because as we know, or as we should know, our breast cancers are presenting in younger women, and they're presenting at a later stage than the rest of the world.
I totally agree with you that we should have a national screening program. So I think Dr. Cooper, that's something that we could work on, right? However, basically, the other question is with respect to our women, because we do get quite a bit of women diagnosed with early breast cancer. Diagnosed with breast cancer at an early stage. So less than 40, what do we do for our recommendations with respect to screening for them? So that would be two things we need to look at. Start at a young age, maybe 35, And can we get a national screening program up and running? And we definitely need to have, education of the population, because you could have a national screening program, but if the people don't go and get the screening, then you're kind of still back at stage one. So you have to make sure that they're aware and that they are, encouraged to go ahead and get their screening when they see their family physicians.
Okay, so we're having a lot of good discussion, good, healthy discussion, lots of food for thought, recommendation. Thank you, Dr. Major, for such a comprehensive talk this morning. One of the things that has come up thus far in the conversation is regarding family physicians. And I think it's very important at this point in time for us to really understand the importance of the role of the family physician. And we really do need to have an education campaign in the country emphasizing this role. I am of the personal belief that everyone should have a family physician. And we really need to promote this. We need to get the general public to understand why this is important. We need to catch these females very early. One of the problems that we are having, as Dr. Cooper would have alluded to, the importance of getting that screening done early in the women around the age of 30. The problem is we don't really have a good culture of young, healthy people coming to the physician just for regular care. So that's one of the attitudes and culture that we need to change. Also in the Bahamas, unfortunately, we don't like to talk about illness. And I think that contributes to why a lot of females are not able to tell you their family history of breast cancer. So we need an entire culture shift. We have a few comments in the chat. Dr. Jermaine Adams says, great presentation. Dr. Isaac said, good morning, excellent presentation. Could you go back through over screening, its importance to make sure that people don't use that to not get screened?
Well, I mean, the main importance with respect to screening is, getting these tumors early, right? And getting them before, they're stage 3, stage 4, and being able to treat them with probably just surgery, maybe even radiation, right? And it's been shown that screening has led to, reduction in mortality. So it is important that we screen these asymptomatic women, again, like it is for the age of 40, and make sure that we encourage them every year to go ahead and get their mammogram, as well as to see a physician with respect to doing their clinical breast examination, as well as them being aware of what exactly their breast feels and look like, so they can determine if there's any abnormality in between the exam and between the screening, that they'll go ahead and they'll get that checked out pretty early, as opposed to waiting until that yearly exam or yearly mammogram. And the other thing is, if we can encourage them, like I say, at the age of 30, they go and they see their family physician and they get their risk assessment, determine whether or not it's an average risk or a high risk woman, because if we know high risk women, they need a bit more intimate screening.
Okay, thank you for that. And this will be a time to put in a plug again here. If you're seeing patients with other specialty, you might be seeing them in, please always ask, who is your primary care provider? It's always good for us to work together. And this is where everyone can do their part to ensure that everyone is connected with a primary care provider, so that we can screen early, we can catch things early, and we can have a healthier population in general. We have another message inside the chat. This one is coming from Dr. Carol. Good morning, and thank you, Dr. Major, for your excellent presentation. What is your opinion of the USPSTF being generally against self-breast exams as a screening adjunct?
Well, I kind of agree with them because how do you generally teach a woman, I guess, the technical way to do a breast examination, you know? And that is why the NCCN doesn't necessarily recommend self breast examination. They recommend breast awareness, which, like you said, basically is just knowing what your breasts look like when you look in the mirror. So you're changing your clothes, you have a look, make sure you don't see any skin changes, you don't see any dimpling, you don't see anything that looks abnormal. You're taking a shower, you know, you do have to wash underneath and above, and you're just kind of feeling as you do that, just making sure that you don't feel anything that's abnormal. Again, you can do this at your leisure because you shower every day, you look in the mirror every day, you can do it every day, or you can do it, you know, once a month, you know, just to make sure that nothing's new is popping up. But to say teach them to do a clinical breast examination, yeah, we generally don't recommend that.
Okay, thank you for that answer. Dr. Spencer Prince says, thank you for this presentation. Though this may be for a different talk, are there any other measures other than screening that can reduce risk of developing breast cancer, since genetics cannot be changed?
Yeah, so great question, by the way. When we look at risk, you know, we classify risk into, you know, modifiable, non-modifiable risk factors, right? So like you say, non-modifiable ones would be your age. You can't change that. Your family history, you can't change that. Genetics, you can't change. But modifiable risk factors, things such as smoking, the foods that we eat, exercising, you know, these things we can change, right? For women, they're estrogen exposure. So one of the things that they look at is, you know, hormonal replacement therapy as well as birth control pills. Individuals who are on these may be at an increased risk for developing breast cancer. Then also breastfeeding, right? So breastfeeding has been one of the things that actually has been shown to decrease the risk of developing breast cancer. So if you have a child, you want to breastfeed that child to try and minimize or decrease your chances of developing breast cancer.
Okay, thank you. Always important for us to focus on those modifiable risk factors, things we can actually do something about. And again, when you get connected with your primary care provider, your family medicine physician, we will gladly go through that with you. We have another message in the chat from Rhonda. I'd like to take this opportunity now to remind everyone on the call to please ensure that your name reflects the name that you would like to be on your BMC certificate. So kindly go ahead and change that for me. Rhonda says, are you seeing men with breast cancer locally? If so, how do they present?
So generally, men with breast cancer, I've seen maybe one. It's not that common. So they would say 1 in 6 to 1 in 8 women will develop breast cancer. But when we look at men, it's like about 1 in 256. So it's not something that tends to happen commonly. And when they do present, they would generally present with a lump in the breast. And then we would go ahead and do the workup with respect to that lump. So they generally get ultrasound, depending on how big the breast is, they may get a mammography, and then, you know, clinical exam and biopsy. So yeah, it's not as common as we see in our women counterparts.
Okay, thank you. And Dr. Carol thanks you for answering her question. Dr. Bassett, great presentation, Dr. Major. As a pediatrician, I started talking to patients about feeling the breast and looking at them from age 13. I think if we start preaching this message early in young adulthood, it will be routine.
I totally agree. You know, you want to start early. You want to get them used to doing these things. And, you know, at the age of 13, I think it's fine for them to be aware of what their breast, what their body feels like, basically. And if there's any abnormality, then they should be, you know, comfortable with telling their parents or comfortable with telling their pediatrician that they may see something that's wrong, and then they can kind of go ahead and determine whether or not that is truly a pathology.
Okay, we have another comment. Dr. Mortimer raised, because of our uniqueness of breast cancer, that is gene pool in the Bahamas, we would have to have our own modified guidelines specific to the Bahamas.
Yeah, I totally agree. So that's something that we can work on. We do have a cancer registry that looks at, breast cancer data as well as all cancer data here in the Bahamas. So it could be something that, we could put together and see what our population is at risk for.
Okay, Dr. Spencer Prince, thanks you for your answer to her question. Bain, good morning. Welcome to our new CME Director, Dr. Wallace Bain. Why, thank you very much. Excellent presentation, Dr. Major. If a woman has increased risk from family history and mammography starts at age 40, what modality do you suggest for ladies younger than the age of 40?
So it all depends on, if you consider them to be increased risk. You can try with the mammogram if they're, let's say, 35, but knowing that, the chance of them seeing anything would be lessened because of the density of their breasts. Most commonly, you'll do a mammogram plus an ultrasound, to try and increase the sensitivity of picking something up. And if you have deemed this woman increased risk, strong family history, or they may have a BRCA genetic predisposition, then you have to add in the MRI, right? Because the MRI now is way more sensitive, but not as specific. So it picks up a lot more. But as you can see in the presentation with the MRI, you have about a 3 times greater biopsy of a benign problem. But again, this is for our high-risk women. For our average-risk women, again, screening starts at 40, but unless they have a first-degree relative that probably was, young, 30, 35 when they were diagnosed, then you may want to now say, okay, let's look at this individual and start assessing them even earlier. So they should probably get an ultrasound at the age of 30, and then kind of you curtail it to their unique situation.
Okay, thank you for that. We have a mic open. Kindly mute your mic unless you have a question. Okay, we have another message in the chat. Cherian Williams, please forgive me if I mispronounced your name. Good morning, Dr. Major. If my mother had ovarian cancer, am I considered at high risk for breast cancer?
Now, great question. So you'd want to look at other family members as well. If any other, like if any of her siblings may have had ovarian or breast cancer, as well as if any of your siblings may have had ovarian or breast cancer. You want to kind of factor in all these things, because if your mother had ovarian cancer, and depending on the age in which she got it, so if she got it, in her 60s or 70s, then and nobody else has it, then you wouldn't necessarily be considered increased risk. It would be good to say put you in one of those risk assessment calculators, and just to kind of truly determine whether or not you are increased risk or not. But you would also want to look at other individuals in your family and see what's happening with them.
Okay, thank you for that. I do not see any other messages in the chat. Wait.
Dr. Bain, can I make one last comment?
Go ahead, Dr. Cooper.
So I just wanted to acknowledge some of the comments that were made about a national breast cancer screening program, which is very important, and it's something that's been identified for quite some time. The need for it has been identified for quite some time. We at NHI have developed national breast cancer screening guidelines that are based on international best practices, but consider the local statistics and the uniqueness of our breast cancer population. We haven't released those yet, but we intend to shortly. But we do want our primary care physicians to know that we're going to make these available. At the present time, we're a little challenged because NHI does not yet cover imaging. And so if you identify a person who is at high risk, who needs to have a more aggressive breast cancer screening protocol, that imaging is currently not covered under NHI, and we're working hard to make sure that that happens soon. But we do realize that that could and probably will create somewhat of a bottleneck in our public sector, where these women will have to go to get either an MRI, or they'll have to get that privately, but if they have to get a mammogram and ultrasound, et cetera. So I just want the primary care physicians to know that, one, we are going to be making the breast cancer risk assessment tool available through probably a link on eClinicalWorks, so that when you see these patients at the age of 30, just asking them a few questions about their breast cancer history, and being able to categorize them as either average risk or high risk. And then the guidelines that we'll be releasing, so that we can give the patients all of the information that they need to make educated and informed decisions about their health, and get those mammograms if it's called for, ultrasounds, or even make the decision, if this is my health, I'm going to make the sacrifice, even though an MRI may not be covered under NHI, but I'll get this, I'll make it happen. So just want to let physicians know that this is coming soon. And if you have any questions or comments, you can kind of give me a call and I'll give you more information.
Thank you so much, Dr. Cooper. We hear you in primary care, family medicine. We hear you, and we look forward to partnering with you to ensure that we can do the best by our patient. Dr. Major, just before we let you go, another question or comment came up, question, and it's from Dr. Bassett. In women with dense breasts, is the pickup rate from ultrasound and mammogram comparable to an MRI?
Well, great question, Dr. Bassett. I would have to say the MRI pickup is much better, right? As like you said, it's pretty sensitive, but then the problem with the MRI is that it picks up everything, right? And most things that it can pick up, or a lot of things that it can pick up are actually benign. So when you've done the MRI and you pick up these lesions, you send these women for biopsies, and then they come back as benign. So like added pretty much stress for an average risk woman. So it's kind of still at the judgment of the physician. So we generally start off with the mammogram and ultrasound for our dense breast women. And if there is any abnormality that they still cannot identify, then they would probably recommend that you do an MRI just to have a look. And this is like a special situation, This isn't for everybody, right? And then the other thing with the MRI too is that when you get an MRI and it shows an abnormality that's not necessarily seen on the mammogram or the ultrasound, how do you biopsy that? Because at present, there are really no MRI-guided biopsies that are being done. All the biopsies that are being done are either ultrasound or mammogram-guided. So that adds another element to the uncertainty of the MRI and the difficulty with respect to interpreting some of the things.
Okay, great. So that now ends the questions, comments in the chat section. Thank you again so much, Dr. Major, for a wonderful presentation. It brought about great discussions. We have a lot to think about. We have a lot to do in this country, and we have to remember to get that screening in early. It saves lives. Just before we go, please don't forget to complete your CME feedback. It's very important for us to be able to get you your CME credits on time. It's approaching that time, so let's get that in so we can get those certificates out to you in an orderly fashion. You guys have been great. It's been a pleasure having you today, and we look forward to seeing you again the last Friday of the month. Have a great day.
Thank you. Wallace, where you been? I feel like I see you.